go ahead, I would like to introduce myself. I'm pharmacist. Good news, Gary. I'm a superintendent pharmacist to Life Health Global Pharmacy here in Warri. Um, Warri, Delta State. Delta State. Okay. I'll be introducing our presenter for today. Our presenter for today, he will be presenting on drug use in pregnancy. And our presenter for today is pharmacist Olusola Ayobami. Hope I pronounced that very well. Pharmacist Olusola Ayobami. Pharmacist Olusola Ayobami is a B Pharm degree holder, an MSc with an M.Sc degree in pharmacology, and is currently undergoing his PhD. He's a lecturer at Department of Pharmacology, Federal University, Ekiti. So today, let's listen attentively and he'll be making a presentation on drug use in pregnancy. Thank you very much. So over to our presenter for today.
Good evening. Thank you, moderator. Please, can we all hear me?
Yes, we can hear you. We can hear you loud and clear.
All right, good evening, everyone. I want to welcome us once again to tonight's presentation. And firstly, I want to express my gratitude to MCPAN nationwide for this opportunity, and particularly to MCPAN Ekiti State Chapter for giving me this opportunity to represent the state. I also want to appreciate our chairperson pharmacist Olanrewaju, for the opportunity I've been given by the association to represent the state. Before I also move forward, permit me to also salute and recognize one of my teachers in person of Professor Olayiwola. Now, I must say that MCPAN is a great initiative at this crucial time when the paradigm is shifting for pharmacy profession in Nigeria and in Africa as a whole. And I want to encourage every one of us, from the leadership to the membership, to keep pushing despite all odds. As the moderator has said, that the catchphrase for 2020 is staying safe. And I hope every one of us is staying safe in our different areas of residence and where we practice. Permit me to also identify and empathize with the pains and struggles youths like me have been through in recent times. And it is my prayer that our nation, Nigeria, will rise above our challenges and become the envy of other nations and become the giant of Africa, which the nation is supposed to be. Quickly, let's run through what we have for tonight. The topic I have before me is drugs in pregnancy. And I want to say this is very important for every healthcare provider to learn and know. What I have here is not exhaustive in itself, but I do hope that by the end of this presentation, our contributions and comments will go a long way in expanding our focus of discussion this night. As we all know that no man is an island, so I welcome our contributions and comments at the end of the presentation. The pregnant women represent a special population or patient population. And we all know that every expectant mother expects to be delivered of a healthy baby. And we know that this hope and this expectation is not just the responsibility of the pregnant mother alone, it is also the responsibility of the healthcare provider to ensure that this dream and expectation comes true. Now, so tonight we'll be briefly running through some of the things we are supposed to know in this particular population. I hope my screen has been shared, and I hope you can all see.
Yes, we can see it.
All right, thank you very much. Now, we all know that pregnancy is the physiologic process of a developing fetus within the maternal body. It is confirmed by the presence of amenorrhea and by a positive pregnancy test, which can be serum-based or urine-based. Human pregnancy lasts for 280 days or 40 weeks, which is equivalent to 9 calendar months or 10 lunar months from the last menstrual period. Now, the period of gestation can be divided into 3 trimesters consisting of 3 calendar months each. I know we all know this fact, but let me just lay that foundation. Everybody takes drugs, including the pregnant women. And it has been found out that between 65% to 94% of women take at least one prescription drug during pregnancy. And nearly 70% of women are taking a medication in the first trimester during organogenesis. It is the wish of everyone to enjoy perfect health, but we know that this might be impossible on a few occasions without therapeutic intervention. The same thing applies to the pregnant population. Enjoying perfect health during this period might be impossible without therapeutic intervention. And this population being a special population, we must equip ourselves with the knowledge of care in this particular population. Now, before I discuss the safety profiles of major classes of drugs during pregnancy, there are some rules we must keep at the back of our minds when we are dealing with the pregnant population. The first is that all patients, particularly female patients, are at risk of pregnancy during their reproductive years. So each time we encounter a female patient in our prime or in our reproductive year, we should clerk to unveil whether the patient is pregnant, or rather we should clerk to rule out pregnancy. It is very important. Before we just jump into therapeutic interventions, we should inquire if the patient is pregnant or not. The second rule is that during pregnancy, medications should only be used if they are absolutely indicated. The pregnancy period or the gestation period is not a period where drugs can just be used as souvenirs. We have to be deliberate and we have to be intentional in the management of this population. So it is important that when drugs are not indicated, we shouldn't use them in this particular population. The third rule is that if possible, we should avoid initiating therapy during the first trimester, because the first trimester is a critical time when organogenesis takes place, and exposure in utero to harmful drug at this time may lead to congenital malformation and teratogenic effect. Now, so if it is necessary to use drugs, then we should select safe medication. And safe medication means that an older drug with a proven track record in pregnancy. We should not jump at prescribing or recommending newer drugs, because of course we know there will be paucity of information, or there will be little or no data about their safety in pregnancy. Because of course, after drug invention, we know post-marketing surveillance takes place, and a drug that has been declared to be safe today might tomorrow be unsafe. So we should be careful when recommending or prescribing newer molecules or newer agents to this particular population. Then if it is also possible, monotherapy should be preferred over polypharmacy in this set of patients. We should use single therapy rather than polypharmacy if it is possible. And also, the lowest effective dose of drug should be prescribed to this particular population. But of course, we also have to consider the pharmacokinetics, and when it is necessary, we should do dose adjustments, because we know that there are physiological changes that may alter pharmacokinetic parameters of drug during pregnancy. And we want to avoid underdosing or overdosing because of alterations, and changes. And as clinical pharmacists, we should discourage the use of over-the-counter drugs by this particular population. Alcohol and illicit drugs have also been known as teratogens, which also discourage patients to which also discourage patients from taking alcohol and illicit drugs during pregnancy. Then we should, as clinical pharmacists, keep abreast of the latest information in epidemiological studies that profile safety of drugs during pregnancy. Now, we know that it is unethical to subject pregnant women to clinical trials to test drug safety, but of course, we conclude on drug safety in pregnancy from epidemiological studies, which can either be core study, which is the best, or the case control study. And sometimes you can also borrow from case reports, but this is not too good. This is a graphical representation of the gestation period. And as you can see from this graph, the embryonic period, which is the period between the 3rd week to the 8th week, is the most critical time when the risk of birth defects being induced by harmful drug is highest. It peaks around the 5th week. And so around this time, we want to avoid initiating therapy to avoid eventual or potential congenital malformation. Now, so to break that to break that down, that graphical representation, I have this next slide. Now, the first day until the 20th day after fertilization, during this period, teratogenesis is unlikely to occur during this period. What we have during this period is what we call the all or nothing effect. And this means that if a fetus is exposed in utero to harmful drug during this time, the drug may either kill the baby, that is, it can be embryocida. If it doesn't kill the baby, then no effect is expected during this time. So exposure in utero to drugs during this time can either be embryocida or we may not have any effect at all. Then the 21st day until the 56th day, this period is characterized by organogenesis, and it is the most critical time during pregnancy. Exposure to harmful drugs during this time can lead to spontaneous abortion, can cause teratogenicity, and can also lead to other hidden embryopathy. The second trimester till delivery, drug exposure is unlikely to cause teratogenic effect, but during this period, there can be, if the baby is exposed in utero, there can be deleterious alterations in physiological functions of fetal tissues and organs. Now, after the exposure of over 10,000 children to thalidomide in the late 1950s, thalidomide was marketed and it was said to be safe as for the treatment of insomnia in pregnancy. But of course, we know what happened eventually to babies that were exposed in utero to this medicine, the development of focomelia and all that. After the exposure to this teratogen, the FDA came up with a 5-letter classification system. Now, but one thing we must note now is that this 5-letter categorization system is now obsolete, is old-fashioned. It has been phased out, or let me say it's been phased out. Now, this 5-letter categorization system includes the A, B, C, D, and X. So as we go down the alphabet, the safety shifts from positive to the negative. Now, so category A represents the group of drugs whose safety have been established using human studies, and this drug will not pose any fetal risk. Category B drugs, for these particular drugs, the safety is based on animal studies. Of course, for this category of drug, we have positive of information from well-controlled human studies. For category C drugs, uncertain safety, because animal studies have shown adverse effects, but we do not have well-controlled human studies for this category of drugs. Then for category D drugs, fetal risk have been shown both in human and animal studies, but of course, benefits may outweigh risk, and these drugs may be used in life-threatening illness or when there are no safer, effective drugs. For instance, most anti-epileptic drugs belong to category D, which suggests that at some point fetal risk has been established. But of course, sometimes when we may have to weigh the benefit of treatment against safety. And sometimes if a woman is under seizure, it could lead to expulsion of the baby. And so we may have to consider therapy in this particular set of patients despite the categorization of this class of drugs. Now, category X drugs are outrightly contraindicated in pregnancy. Fetal abnormalities have been established in animal and human study, and risk outweighs any possible benefit. So these drugs... Can I continue?
Yes, please continue. Continue.
All right, so these drugs are outrightly contraindicated in pregnancy. Now, so why has this categorization system become obsolete? It became obsolete because approximately 60% of all drugs are listed as category C, indicating that there is limited information about their safety. And so this 5-letter system is being phased out in favor of a more comprehensive system with a better narrative. Now, what we now use, or what the FDA recommended, is what a part of it is what I call the pregnancy and lactation labeling rule. And this rule removes the pregnancy letter categorization. What this rule helps to summarize the risk, the potential risk of medications, and it is also updated when information becomes out of date. Like I said earlier on, a drug that has been declared to be safe today may tomorrow be unsafe. So as information is being updated, this PLLR also ensures that the labeling of such drug is also updated. Now, we will now quickly run through some major classes of drugs and profile their safety in pregnancy. Vitamins. Folic acid belongs to category A, and drugs that belongs to this category are completely safe in pregnancy. Of course, we know that folic acid is very, very vital. It is important pre-conception, during conception. In fact, deficiency of folic acid in itself can induce teratogenic effect. So if a pregnant mother is deficient of folic acid, we know that this is not too good for the developing baby. Now, the vitamins B1, B2, C, and E belongs to category A within the recommended daily allowance or within the recommended dietary allowance. As clinical pharmacists, we must ensure that our pregnant patients do not overdose on vitamins, because when doses above the recommended daily allowance is being, when vitamins are taken beyond the doses of the recommended daily allowance, it shifts the safety from the positive end to the negative end. So we must ensure that when our pregnant patients are taking vitamins, it must be within the recommended daily allowance. Vitamin A is known to be teratogenic at doses above the recommended daily allowance. So we should ensure that our pregnant patients are not overdosing on vitamin A. Now, the other vitamins belong majorly to FDA category C. Now, they can be used, but their use should be kept within the allowance for use during pregnancy. Now, generally, balanced diet should be encouraged during pregnancy because it may help solve the problem of taking so many vitamins when this population eats or takes balanced diet. Now, we know that even ferrous may not be that important if the mother is not anemic, or if the mother is feeding well, it may not be all that important. And the most important vitamin is the folic acid, which is important pre-conception and during conception. For the antibiotics, we have various classes of antibiotics. The penicillin, cephalosporin, macrolides, nitrofurantoin, and vancomycin ora all belong to the FDA category B. Penicillins belong to FDA category B, and they are one of the safest classes of drugs that can be used during pregnancy. All cephalosporins, like penicillins, also belong to FDA category B, and this class also represents one of the safest classes of drug that can be used in pregnancy. But of course, we know we have newer generation of cephalosporins. For instance, ceftaroline is a 5th generation. And like I said, for newer drugs, we have paucity of information on their safety in pregnancy. So caution must be exercised before prescribing this newer agent in pregnancy. And there is something important we must also note about ceftriaxone in pregnancy. It should be used cautiously at term due to the potential risk of kernicterus in neonates. Kernicterus is brain damage consequential to high bilirubin level in neonates. In fact, this is the major reason why ceftriaxone is also not recommended in NICU, because of the risk of kernicterus. So it's not really an antibiotic of choice when we consider safety against benefits. All carbapenems, like the 2 previous classes, also belong to FDA category B, except for imipenem cilastatin, which belongs to category C. But the thing about carbapenems is that they are reserved for pregnant women with infections that are resistant to penicillin and cephalosporin. So they are not first-line antibiotic for use during pregnancy, although they are safe, and imipenem cilastatin may not be a safer option or the safest option during pregnancy. For macrolides, erythromycin and azithromycin can be used because they belong to FDA category B. But there's something about the different salts of erythromycin. Erythromycin estolate can induce hepatotoxicity in pregnant patients. So these salts should be avoided. Erythromycin stearate can still be used. Now, clarithromycin, telithromycin are not safe options for macrolides during pregnancy. Nitrofurantoin is commonly used to treat UTI, but there's a risk of hemolytic anemia in newborns in the 3rd trimester. So caution should be exercised when prescribing nitrofurantoin in the 3rd trimester. For category C antibiotics, quinolones and chloramphenicol should be avoided in pregnancy, except if there are no safe alternative. Then we may consider using them, but they should generally be avoided. And chloramphenicol, particularly because at term it may cause gray baby syndrome. The category C, D antibiotics, we have the tetracycline aminoglycosides. The tetracyclines are contraindicated in the 2nd and 3rd trimester because they interfere with bone mineralization. And the aminoglycoside, there is a study that has associated the use of streptomycin to irreversible bilateral deafness in newborns. So we want to exercise caution. The only time we use this class of antibiotics is when there are no safer or safe alternatives. Now, for the antifungals, the safest for vaginal thrush in pregnancy is nystatin pessary. We must take note of that dosage formulation. The pessary is safe to use in pregnancy because it belongs to category B. And for systemic fungal infections in pregnancy, amphotericin B can be used. It belongs to category B. Terbinafine is approved for the treatment of onychomycosis, but of course we must weigh the benefits against the risk before initiating treatment for onychomycosis. Azoles generally should be avoided during pregnancy, especially in the 1st trimester. Now, all azoles belong to FDA category C, but fluconazole, multiple doses of fluconazole shift the safety from the positive end to the negative end. Single dose fluconazole belong to FDA category C, but when we start recommending repeated doses, it shifts the safety to the negative end. But generally, we should know that azoles should be avoided during pregnancy. they are better taken as topical agents than oral agents. Fusin, grisofulvin, is outrightly contraindicated in pregnancy, and in fact, it should be avoided for 1 month. Sorry, pregnancy should be avoided for 1 month after treatment with grisofulvin. So if a woman in her reproductive year is planning pregnancy and the person has taken grisofulvin, pregnancy should be avoided for 1 month after treatment. Most antiemetics can be used during pregnancy. They are safe to use during pregnancy, and this slide is showing us the various classes that we have, except for ondansetron that should be avoided in the first trimester. The others can be taken. Doxylamine belongs to FDA category A. Cyclizine, meclizine, metoclopramide belongs to FDA category B. Promethazine is also safe to use. Now, but as clinical pharmacists, we must keep updating our knowledge from epidemiological studies that has to do with safety of some of these medications in pregnancy, because a study might just come up tomorrow that will find an association between a safe drug and a particular congenital effect. For GI drugs or anti-ulcer drugs in particular, the histamine 2 receptor antagonists are safe to use in pregnancy, and they are recommended, particularly cimetidine and ranitidine. All PPIs should be used with caution because they belong to the FDA category C. Also, antacids can be used because most of them are not, or some of them are not systemically absorbed, so they can be used during pregnancy for heartburn and dyspepsia. For malaria, we know we are in the tropics, and one of the important things we must also consider in pregnancy is malaria and the eventual complications that may come if we leave this particular infection or this particular disease untreated. Now, chloroquine does not belong to any FDA category, and it can be used across all trimesters for sensitive parasites. We know the problem we have with this particular molecule is that of resistance. So perhaps if the parasite is sensitive, chloroquine can be used across all trimesters. Quinine also has not been shown to be risky in first trimester, but of course we must note that at abortifacient doses, quinine can be teratogenic. Artemether lumefantrine is recommended to be taken in the second and third trimester, but of course there's a CDC guideline that suggests that we may consider for first trimester use if there are no other safe alternative. Then, of course, during pregnancy, we know that the high PTP, we use at least 3 doses of sulfadoxine pyrimethamine 1 month apart, beginning from the second trimester. It is important because we want to avoid using SP during organogenesis. Now, for analgesics, there are several studies that has found an association between continuous use of high dose of acetaminophen and maternal anemia. An association has also been found between continuous use of high dose acetaminophen and asthma. An association has also been found between continuous use of high dose acetaminophen and fatal kidney disease in newborn. But of course, acetaminophen is still one of the safest analgesics that can be used in pregnancy recreationally. Aspirin is safe at antiplatelet doses. Of course, we know that it can be used prophylactically to prevent some cardiovascular diseases during pregnancy. NSAIDs are best avoided in pregnancy, particularly in the first trimester and third trimester, because when we use them close to term, it might cause premature closure of the ductus arteriosus, which can predispose the newborn to pulmonary hypertension. A lot of pediatric patients come down with pulmonary hypertension. Well, an association has been found between NSAIDs and the premature closure of arteriosus, premature closure of the ductus arteriosus which eventually will cause pulmonary hypertension. Diabetes mellitus is a biologic teratogen. Now, so when there's hyperglycemia in pregnancy, we want to treat the hyperglycemia because congenital abnormality can ensue from that disease state. Some of the complications of diabetes in pregnancy include congenital abnormality, stillbirth, macrosomia, hypertensive disorders, and increased rate of cesarean section, which can be consequential to macrosomia. Now, diet control is the first thing to initiate when a pregnant mother has high blood sugar. And insulin has been the mainstay of treatment for hyperglycemia. All insulins belong to FDA category B, except for glargine, which belongs to FDA category C. Also, the NICE has advised that metformin may be used as an oral agent during pregnancy. Others should be avoided because associations have been found um, between their use and with some other teratogenic effects. For high blood pressure, angiotensin converting enzyme inhibitors and angiotensin receptor blockers should be avoided because they may be teratogenic. And other medications contraindicated, other cardiovascular drugs that are contraindicated in pregnancy include diuretics. Diuretics will pose the risk of hypovolemia when used during pregnancy. And statins belong to FDA category X. They are outrightly contraindicated in pregnancy. They should not be used in pregnancy. In fact, it is a fact that cholesterol is needed for adequate fetal growth and development. So there is no need to bring down cholesterol during pregnancy. And more so because most of the anti-dyslipidemic agents that we use are teratogenic. The antihypertensives recommended during pregnancy, we have the methyl labetalol and nifedipine. They are acceptable oral antihypertensive agents in pregnancy. Of course, if you have issues with venous thromboembolism, heparins are used for the management of venous thromboembolism. Now, the reason why heparins are used is because they have high molecular weight. Now, for drugs whose molecular weight are greater than 600 Dalton, these drugs will not be able to cross the placenta. So in utero exposure will not pose any risk. In fact, that is the reason why insulin is a mainstay of therapy for diabetes mellitus during pregnancy, because insulin also has a high molecular weight and it will not cross the placenta. So for drugs that have high molecular weight and do not cross the placenta, they can be safely used during pregnancy. And unfractionated heparins represent one of these high molecular weight drugs. So if we need anticoagulant during pregnancy, low molecular weight heparin can be used. Unfractionated heparin can be used. The oral agent warfarin is outrightly contraindicated during pregnancy and its use should be avoided. There are investigations going on for direct acting oral anticoagulant and their safety in pregnancy. For antiviral agents, ribavirin is outrightly contraindicated in pregnancy. It's an anti-HCV drug, and in fact, it should be discontinued at least 6 months before planned conception. Acyclovir is safe. For HIV and AIDS, of course, we know it is essential to reduce perinatal transmission in infected mothers, and we do not need to consider several classes of drugs for this because TLD, tenofovir lamivudine dolutegravir, is now the preferred choice since WHO announced it is safe for women of childbearing age. Now, let's now come down to epilepsy during pregnancy. Like I told us, if a pregnant mother falls under seizure, it may pose risk to the baby she's carrying. And of course, with some other complications that come with epilepsy. And like I said, most of the anti-epileptic drugs belong to category D. which questions their safety in pregnancy. But of course, when we summarize what category D drugs are about, we said sometimes when the benefit outweighs the risk, we can use these drugs. But there are some guidelines we must follow if we are going to recommend anti-epileptic drugs during pregnancy. One, high dose folic acid supplementation is recommended 3 months before conception and all through the conception period or all through the gestation period. Then we must also know that sodium valproate adversely affect neurodevelopment in the newborn, and we must apprise the patient of this information that, of course, if you expose your baby in utero to sodium valproate, it may affect the neurodevelopment in the newborn, so that, of course, the mother will know what to expect or what may likely happen. Now, carbamazepine and lamotrigine will not adversely affect neurodevelopment, but we have little evidence or little information for levetiracetam and phenytoin in pregnancy. Then another rule we must follow, another guideline we must follow is that the lowest effective dose of the most appropriate anti-epileptic drug should be used during pregnancy. Then another important thing is that all babies born to women with epilepsy taking enzyme-inducing anti-epileptic drugs should be offered 1 milligram intramuscular vitamin K to prevent hemorrhagic disease of the newborn. In fact, in the 3rd trimester, the use of oral vitamin K 10 milligrams per day is recommended for the mother to also prevent the hemorrhagic disease of the newborn. Here I have a list of the enzyme-inducing anti-epileptic drugs, and I have a list of the non-enzyme-inducing anti-epileptic drugs. Among the anti-epileptic drugs, the lamotrigine, levetiracetam, and carbamazepine monotherapy at lower doses have the least risk of major congenital malformation in the offspring from meta-analysis and several cohort studies. These three molecules in particular have the lowest risk of major congenital malformation. Now, to summarize, all these drugs are outrightly contraindicated in pregnancy because of their category. All statins are contraindicated. Warfarin, most abortifacients, misoprostol, castor oil, Orlistat, methotrexate. I mentioned some of these earlier in the course of the presentation. Most androgenic drugs are contraindicated, and most estrogenic drugs are contraindicated. Isotretinoin, okay, I don't think I'm permitted to mention a particular brand, but of course, isotretinoin is an anti-acne medication and is formulated topically. Maybe there are other dosage forms too, but this drug should be avoided in pregnancy because it is also teratogenic. Some BZDs, benzodiazepines, are also non-teratogen and should be avoided during pregnancy. These are my references. I want to apologize for the brevity of the presentation, but I know by the time our comments and contributions come in, it will further expand the discussion. Thank you for listening. Thank you very much.
Wow. A round of applause for pharmacists Olusola and Ekiti State MCPAN. A round of applause for them. Thank you very much for this wonderful presentation. It was really enlightening. Okay, there's a message on the chat group. If you have a question, you can raise up your hand, and also, or you drop the question and you'll be unmuted for that. But before we continue, before we take the questions, I would like to recognize all MCPAN executive in the house. You are highly recognized, and including our MCPAN chairman, national chairman, and all state executives. You are all welcome to this presentation. Okay, we are set to take questions now. We're set to take questions. So Uma Yerima has a question. So your mic will be unmuted now, so you can ask your question.
Yes, you can unmute yourself and ask the question. Yes.
Okay, please, Uma Yerima, you can unmute yourself from your from the participants group. You can unmute yourself and ask your question.
Hello, good evening.
Okay, good evening.
Thank you for the wonderful presentation, Mr. Presenter. My question is, what are the herbal products that should be avoided during pregnancy? Thank you.
All right, Mr. Presenter.
Okay.
Did you hear the question?
All right. Yes, I got the question.
All right.
I should have also covered herbal medicine or alternative and complementary medicine. But of course, we know that there are paucity of information, or there are little or no adequate studies to establish their safety during pregnancy. And most of the animal studies we have that has to do with reproductive toxicology, data from these animal studies cannot be extrapolated into human experience. And so it is best to avoid most of these herbal medicines during pregnancy. In fact, when I was preparing for this, most herbal medicines do not belong to, in fact, the popular ones, most of them have no FDA categorization, and they do not belong to any category. And some of them have oxytocic effect, and we never can tell. So we should not encourage this population of patients to take herbal medicines. Thank you.
All right. Pharmacist Uma, I think that's clear enough. Presenter said we don't encourage herbal medication for pregnancy, for pregnant ladies. Okay, there's a question on the group chat. I'm going to read it out. It said, this question is from Nkechi, Okechi. Okay, she said, what do you have to say about supplements like A to Z containing multiple vitamins and minerals? How safe are such in pregnancy?
Okay, thank you very much. I said it during the course of the presentation that the most important thing about vitamins is to ensure that they are taken within the limit of the recommended allowance. If these vitamins are taken within the limit of the recommended allowance, then they are safe to use during pregnancy. And we must also know the level of vitamin A, which is an established teratogen. If the vitamin A in this supplement is above, which is unlikely, is above the recommended allowance, then the use of such supplement should be discouraged. Then if the supplement contains other molecules or other drugs whose safety has not been established during pregnancy, we may want to avoid recommending such supplements. Thank you.
All right, thank you for that. That's okay. We have Ifeyinwa Chijoke has a question. The hands are raised. All right, you can unmute yourself, please. Hello, Ifeyinwa, you can unmute yourself now. You can unmute yourself and ask your question.
Okay, thank you. Can you hear me now? Can you
yes,
hear
we
me?
can hear you loud and clear.
Oh,
we can
good
hear
evening,
you
everyone.
loud and clear.
Okay. Thank you very much, presenter. It was an excellent presentation. Very, very good presentation. I think I missed what you said about the most appropriate drug, anti-epileptic drug use. You said something, the most appropriate anti-epileptic drug for use in pregnancy. Please, I would like to get that. I think I missed that. Thank you.
All right, thank you very much. I didn't say the most appropriate, but of course I said that from several studies, now it has been found out that there are 3 antiepileptic drugs that have the least association with congenital malformation. It is not that they are
Okay.
absolutely safe, but of course,
All right.
cohort studies came to conclusion that there are 3 in particular that have the least association with congenital malformation. And I mentioned carbamazepine. But of course, when carbamazepine is being used, folic acid supplementation is very important. Lamotrigine and levetiracetam. Thank you.
Okay. Okay. Thank you very
Oh,
much. Thank you.
all right. Thank you for that. All right. I'm going to read a question now. It said, you did not mention, this question is from Informa. It said, you did not mention ajalazine among the oral antihypertensive that can be safely used in pregnancy. I wonder why, because they are, okay, it's being used in my institution. Please, can you throw more light on it?
All right, thank you very much. Like I said, like I said earlier, rather, that the presentation is not exhaustive in itself, and that by the time comments and contributions start coming in, of course, it will also throw more light, and we have more things to add. It wasn't intentional, and of course, it can be used during pregnancy.
All right. Okay. Um, Bola Ola Yiwola has her hands are raised. So please, you can unmute yourself now. Bola, you can unmute yourself and ask your question.
Professor Gola Olayiwola is my teacher. I may not be able to answer any question from him.
Okay.
Thank you. No. Yes. Mhm. I appear a presenter. That was it. No, I'm not going to ask questions. I just want to add or strengthen because for a pharmacology specialist, and when you were there, I was expecting that.
Hello, the network from Professor Bola seems bad. Hello. Hello. Okay. I
Lost
guess
him, so go on.
yeah, we lost him. Okay. Okay. I'll read another question now. Okay. Someone asks. Is saying. Okay. Someone is saying. Dr. Arinola said, can you provide the RDA for vitamin A? That's the required daily allowance for vitamin
Right.
A.
I'm not sure I have that information at my fingertip. But like I said during the presentation, that those beyond 8,000 IU per day should not be used, because
Okay.
of course these will cause teratogenic effects.
All right.
But
Okay.
I know the RDA is very much lower than that.
Okay. Okay. All right. Thank you for that. Okay. Next question says that's from John, from pharmacist John, saying, what is the safety profile for vitamin E in pregnancy?
Okay. Can I?
Okay. It seems.
Come back now.
Yes. All right. Professor Bola is back online now. Okay. Hello. We lost him. Okay. We lost him again. So I'll continue reading the questions now. It said, okay, what's the safety profile for vitamin E in pregnancy? Pharmacist Abayomi, Olusola.
Okay, like I said that most of the other vitamins belong to FDA category C. Vitamin D can be used in pregnancy too. It's safe to use in pregnancy from the little I gathered before preparing for the study. But I strongly recommend that the pregnant population should get more of their nutrients or nutritional, should meet most of their nutritional demand from balanced diet. It is very important that from fruits, vegetables, and other vitamin-dense meal. Thank you.
All right. Okay, thank you for that. Okay. Okay. Dr. Arinola is also asking. Sorry, Dr. Arinola is asking, did you say vancomycin is safe in pregnancy? Hello, Pharmacist Olusola, are you there?
Yes, I said oral vancomycin is safe, but of course, we must know that there are safer alternatives, and it does not exclude the fact that there may be an association between the use of this drug and probably a teratogenic effect. Now, maybe the person that asked that question has an information on its use in pregnancy, which we'll be glad to, or I'll be glad to know, basically.
Okay, Dr. Arinola, I don't know if you can hear us, but if there's if there's additional information you would like to provide, you can actually raise your hand, or you can drop the message on the chat. You can raise your hand, so you'll be unmuted and you can speak out. All right, Dr. Solomon said, good ezetimibe is safe in, it's a good presentation, but ezetimibe is very safe in pregnancy in respect to dyslipidemia. Okay, that's a contribution. Ezetimibe is very safe in pregnancy in respect to dyslipidemia. All right, so he said, thanks to the presenter for a beautiful presentation. Please, if FDA category is obsolete, I expected you will expand a little more on the recent categorization. Administration of vitamin K, is it to the pregnant woman or the baby? Please, what's the hypertension? Okay, I hope I'm not too fast in reading the question. I'll take it again. If FDA category, this okay, there's no name from the sender. If the FDA category is obsolete, I expected you will expand a little more on the recent categorization. Administration of vitamin K, is it to the pregnant? So the person is asking if administration of vitamin K, is it to the pregnant woman or the baby? Then another question again, what's the antihypertensive of choice in cases of hypertensive emergency in pregnancy? I'm Olusola, over to you. Did you get the question?
Yes, but I hope I'll be able to remember the three questions. Now, for the first question, I said
Okay.
the FDA categorization is now obsolete. Now, what we now have is a new labeling rule. There is no categorization system again. There is no letter categorization system. What the FDA has proposed is that drugs should be comprehensively labeled. And what I mean by comprehensively labeled is that if you are labeling a drug or if you are profiling a drug for safety in pregnancy, you must provide us with results from animal studies. You must provide us with results from epidemiological studies, and you also must provide us with the safety profile for fertility. In fact, you must provide us with a lot of details about the drug and reproductive toxicology. And not just provide us with details, as new information comes in, you must update the labeling, or you must update the label to accommodate the new information you have. So there are a lot of things under the new labeling rule, which I may not be able to mention all. Of course, I've highlighted some of the things you find there. But the reason why I didn't go into much details is because the most important thing for the new labeling rule is the risk summary. You may not be able to go through some of the details, but of course, when you find the risk summary, you can conclude on the safety of such medicine during pregnancy. I hope I've been able to clearly answer that question. Then for the second question, please can you remind me?
Okay, the second question is, in the administration of vitamin K to pregnant women, is the vitamin K administered to the woman, as in to the pregnant lady, to the pregnant woman, or the baby? Or the baby? That's the question.
Yes, I said in the last trimester, particularly for women with epilepsy, oral vitamin K supplementation is needed for the mother and for the baby after the mother has been delivered. Parenteral vitamin K can be given.
All right. The last question is, what's the antihypertensive of choice? That's the last question from this same sender. Please, what's the antihypertensive of choice in cases of hypertensive emergency in pregnancy?
Okay, I attended the last presentation. Then I think we mentioned this question also came up in the last presentation, and people mentioned a lot of antihypertensives that can be used for this condition. And like I've mentioned, the ones that are mentioned that are recommended to be used during pregnancy can be used, hydralazine inclusive.
Okay. All right, thank you. Okay, I think this question is actually very prominent for, most especially for community pharmacists. They said many pregnant women come to the pharmacy to get cough syrup. Cough syrup should be avoided. Okay, what cough syrup should be avoided in pregnancy? That's one. How do you treat diarrhea in pregnancy? And what's first aid for diarrhea in pregnancy? That's all wrapped up in one. There's another. I'm going to read the questions so even as but let me just read everything. So, same person again also asked, why do we give 5 milligram daily folic acid to pregnant women rather than 400 microgram daily recommended dose?
All right, thank you. I don't know if other people can help out too.
Okay.
Because I wouldn't mind if other people to help out, because I do not want to just be the only person talking during this presentation. So if I can get help, I would appreciate it.
Okay, please, our presenter needs more comment and contribution. Okay, I would like to answer the one for the folic acid as regard the folic acid. Now, the one for the folic acid says, why do we give 5 milligram daily folic acid to pregnant women rather than the 400 microgram daily recommended dose? Well, the main reason is actually its production technology. Most our common folic acid that we see here that's locally made, is readily made into 5 milligram, which is like 5 milligram, which is the technology which they use. They can't, because 5 milligram is very minute, they can't actually make it into that available dose. That's why you see that companies some companies, like I'm going to call some companies, the readily available folic acid 400 milligram. If you look at some of those feeds dose combination, you see the actual dose there because of the technology they use in producing them. But our local companies here, they because of the raw materials they use, the best they can actually produce is that is being represented in their dose. It's 5 milligram in opposition to the required daily dose. But the recommended dose is between 400 to 800 microgram for folic acid. I don't know if I've answered that question very well, but that's to the best of my knowledge. That's for folic acid and for folic acid. So there are more questions there that talks about what cough syrup should be avoided in pregnancy. Anybody to contribute? Olusola, the floor is still set for you.
Okay, all right. Personally, I do not believe in. I do not believe cough syrups are a class of essential drugs. Well, I believe that cough can be managed if you know the cause and probably eliminate the cause. If it is infectious in nature, antibiotics can be prescribed. If it is due to maybe an allergic respiratory disorder, or if it is probably due to some other causes, the cause should be known and the cough should be treated. But generally, antihistamines can be used during pregnancy. And of course, we know that some of these cough formulations also contain antihistamine. Thank you.
Okay. Okay, we have a lot of persons raising up their hands, so I'm going to call them. Please, let's be very brief in our contribution. Okay, I'm going to call Dr. Ejo for his own contribution question. Dr. Ejo, please, you can unmute yourself. Dr. Ejo, you can unmute yourself. Dr. Ejo, I said you can unmute. Please unmute yourself. Okay, I think we've lost him. All right, pharmacist Precious Ikenna. Please, you can ask your question. You can unmute yourself and ask your question or your contribution.
Good evening, Garant pharmacist.
Good evening.
I commend the presenter. I really commend the presenter. The presenter really did a nice job. He did a very nice job.
Thank you very much, sir.
Okay.
Keep it up, sir. Is magnesium sulfate. My question is on magnesium sulfate. Is it safe? Is its use safe in pregnancy?
Okay, all right.
Okay,
magnesium sulfate.
Okay, from Olusola.
Of course, magnesium sulfate is a drug that is commonly used in obstetrics. So it is safe in pregnancy. But of course, we must exercise caution. I think the use of magnesium sulfate should not extend a certain consecutive days when we want to use magnesium sulfate in obstetrics. Then also, of course, we know it has an antidote, and that must be kept beside when we are using magnesium sulfate during pregnancy. But of course, magnesium sulfate is one of the little armamentarium of medication that is used in obstetrics, so it is safe.
Okay, thank you, sir.
Okay, thank you for that. Okay, raised hands. Okay, if I Chijuke want you, please you can unmute yourself and ask your question. If you want, so if you want Chijuke, please you can unmute yourself and ask your question.
I've asked my question before.
Okay, okay. Dr. Ejiro.
Sorry.
Please, you can unmute yourself and ask your question. All right.
Yeah. Well, mine is not really a question.
Okay. Okay, comment. Hello, Dr. Ejiro, are you there? Hello, Dr. Ejiro, can you hear me?
To do it, drugs study. But I think he did a very good job running through most of the medications used in pregnancy. So for the specific, because the questions coming in now seem to be for specific conditions and specific group
I've omit myself
of medication. Maybe for subsequent meeting, we may need to focus on specific disease states and specific conditions, medications used in such conditions. I want to very much appreciate the presenter for running through all the medications as he did.
Okay. Okay, thank you very much, our presenter. All right, please, there are some contributions that have been made on the chats, on the comment box. For time, we won't be able to read all of them, but you can easily just go through them and see the various contributions that have been made there. The one as regard the cough, Dr. Lauer said cough syrup should be avoided in pregnancy, especially in the first trimester. If you must give, then piriton expectorant is preferred. I think that then loratadine is very safe in pregnancy from precious incanal. So those are various contributions that have been made. Then someone also made contribution to say the safest antiemetic in pregnancy is mebendazole. That is also contribution. Okay, I think we've touched. Additionally, Dr. Solomon, a contribution, I'll just read this one. He said, additionally, most cystic women nutrients here lack composition of vitamin B9, which is folic acid. So the 5 milligram is our tropical formulation. Yes, so that's what we said the other time, that what we have common here is the 5 milligram is our tropical formulation. So any other question before I call on the any other question?
Dr. Kamal is Dr. Kamal. Dr. Kamal is using her name. Dr. Kamal can go ahead, yes.
Yes, can I talk?
Okay, yes. Okay, doctor. Yes, you can talk.
So my name is Pharmacist Kamal from Pharmacology Center, Ekiti. Actually, I want to appreciate the presenter. I've carefully listened to his presentations. My own just to share information regards to several questions that's raised. The presenter earlier told us that the earlier categorizations by FDA is absolute, and I undergone a study during my master program, which was related to the topic presented. And the topic was drug exposure during pregnancy and neonatal risk assessment. It's in line with what the presenter was trying to has presented to us, risks of those drugs to pregnancy. In that research work, we look at drug exposure in pregnant women, and we assess the outcomes of the pregnancy to see which class of drugs are really have teratogenic effect to the fetus. But what we did that look most different, we tried to bring a new classifications based on the drug exposure we encounter into 3 classes. That's one, the drugs that are safe, those that are low risk, and those that are high risk. And because of what the presenter earlier told us that pregnant women are exclusively excluded in the clinical trial because of unknown information about the drug effect on the fetus. Post-market surveillance keep on tracking more drugs that are having newer information on teratogenic effect on pregnant women, on the babies and the women themselves. We used a book that was titled Drug Use in Pregnancy and Lactation. That book has a comprehensive list of drugs, not just classifying them as they are either they are teratogenic or they are not used or not used, but it goes ahead to tell us what kind of effect that drugs can cause, and at what stage of pregnancy that drug can affect the pregnancy, the baby. So we use that textbooks. It was written by Briggs and his groups. I'm trying to get the name before I conclude that. We use that book to classify the list of drugs we encounter as safe, either safe or low risk and high risk. Those drugs that are classified to be safe found to be they could not have any effect on any stage of the pregnancy, either first trimester, second trimester, or third trimester. And those that were said to be low risk are those who had only effect in the second and third trimester, and the high risk drugs we classify them as those drugs that had effect on all stages of pregnancy, that is first, second, third trimester. I'm bringing this information for some of us that have interest in obstetric pharmacotherapy. Most of the questions asked, those books have detail of each individual drugs and the effect and at the stage that they exhibit those effects. It helps us as a pharmacist to take decisions in addition to the categorization, the categories the FDA has given us on ground. I think that book is constantly being reviewed, at least every 3 years, include most information, new information gotten from post-market surveillance of those drugs. As we all know that they are not initially included in clinical trials, but as they are continual post-market surveillance, they keep us updating those books. I will beg the leadership of this forum, maybe in the next subscriptions, I will provide detail of those books so for those who are interested in obstetric therapy can have them for their necessary practice. Thank you very much. I appreciate everyone.
All right. Thank you, Kamal, for that wonderful presentation. All right. Briefly, I know we spent a lot of time today. I will call on Dr. Felicia Williams to give a comment or ask a question. Please, you can unmute yourself. You can unmute your mic. You can unmute yourself, Dr. Felicia Williams.
Good evening, everyone.
Hey, good evening.
I want to talk briefly on vaccines that should be avoided. Can you hear me?
Yes, we can hear you. Can hear you loud and clear.
Can you hear me?
Yes, we can hear you loud and clear.
Hello?
Can hear you loud and clear.
The vaccines that should be avoided during pregnancy include human papillomavirus vaccine, measles, measles, mumps, and rubella vaccines should be avoided. Live influenza vaccine, that's for nasal flu vaccine, should be avoided. Varicella, that's for chickenpox, also should be avoided. For women that are traveling, it's also recommended that you avoid yellow fever, typhoid vaccine, and Japanese encephalitis vaccines. We want to really remember this for vaccination of pregnant women so that we can encourage them to avoid these vaccines during pregnancy. Thank you.
Okay. Thank you very much, Dr. Felicia Williams, for that wonderful contribution. Okay, is there any other contribution that I'll just call before we wrap up today? So I want to call our national chairman for closing remark. National chairman, sir. Chairman, sir.
Hello?
Hello? Hello?
I don't think he's on the line again, so maybe.
Okay. Okay, so maybe you can give a, okay, so that we can give a closing remark.
Okay. I want to thank everyone for making today a reality, especially we thank our speaker for that beautiful job and for that information, very thorough and very educative. We thank all of you for participating, for staying up to the end of the thing. We thank you. I will pray this add to the body of knowledge and be of benefit to humanity in general. Next week is going to be another good day. Thank you for coming. Thank you, and God bless us.